Dear committee and audience, let me introduce my PhD student Dorottya Bastidas-Gergő, who was born and raised in Budapest, Hungary. She graduated from Attila József High School and continued her studies at the Faculty of Natural Sciences at Károly Eszterházy University in 2013, specializing in laboratory biology. During her studies, she was a TDK student of Szabolcs Molnár on the topic of instrumental analytical examination of domestic and foreign propolis samples with special attention to the flavonoid composition. In 2016, she was awarded second place for her project at the National Student Research Conference. After graduation, she continued her studies at the Faculty of Information and Technology and Bionics at Péter Pázmány University in 2017, earning a master's degree as a medical biotechnologist. She completed her thesis project at the Institute of Enzymology at the Research Center of Natural Sciences in the Hungarian Academy of Sciences under the supervision of Dr. Anna Brozik. Her thesis focused on the effect of therapeutic cytostatics on the expression of ABCG2 multidrug transporter in lung adenocarcinoma cells. Following this, she began her PhD studies in 2019 in the Department of Pharmacology and Pharmacotherapy at Semmelweis University and later continued at the Department of Pharmacognosy. In 2022, she joined the Center of Translational Medicine program under my supervision on the topic of efficacy and safety of natural products in the evidence-based medicine. In her second year, she became a scientific methodology supervisor, guiding 11 PhD students from pediatrics and cardiology groups. Since 2024, she has been working as a study startup clinical research associate, supporting clinical trial initiation across multiple indications. Dorottya is a highly dedicated and hardworking student with excellent time management skill. She attended several conferences where she presented her scientific work. In her free time, Dorottya values spending quality time with family and friends and enjoys traveling to exotic destinations. The road that led to today was not easy and straightforward, but Doris' determination and hard work overcame every obstacle. She has demonstrated significant growth during her PhD studies, and she is now ready to present her achievements to you. Thank you. The floor is yours.
Okay, dear audience, I would like to welcome you on my PhD defense and present to you my topic, which is the assessment of efficacy and safety of natural products in evidence-based medicine. My name is Dorottya Bastidas-Gergő. I am a medical biotechnologist and a PhD candidate in the Department of Pharmacognosy. My vision is that the evidence-based use of herbal products will be more widespread in the medical practice. And to achieve my vision, my mission is to provide scientific evidence for health professionals to facilitate their work and their evidence-based decision-making when applying herbal products. My PhD focused on 3 topics: the assessment of efficacy of peppermint on nausea and vomiting, the efficacy and safety of L-menthol during endoscopy, and Elixirium timicompositum in the treatment of acute bronchitis in pediatric patients. My first project is inhaling peppermint essential oil in the treatment of nausea and vomiting, and we conducted this project with the method of systematic review and meta-analysis. Nausea and vomiting are common symptoms, and they can be experienced by several reasons. Every year, there are around 75 million surgery patients, and around 1/3 of them experience nausea and vomiting symptoms. Also, the symptoms can affect 40 to 80% of the cancer patients during their chemotherapy, and worldwide, around 70 to 80% of the pregnant women experience the symptoms as well. The causes share some common factors, and these can be triggers, including medications like anesthesia or opioids, or also hormonal factors like elevated levels of estrogen. And these factors are involved on key neurotransmitter pathways like serotonin or dopamine receptors. And to reduce the symptoms, the standard treatment include, for example, 5-HT3 receptor antagonists, dopamine antagonists, and so on. But these current antiemetics can be ineffective in some cases, or also can come with adverse events. Also, in the case of pregnancy, it is very limited what the women can use. So for these cases, an alternative is needed, and aromatherapy it could be a good option. And peppermint oil is considered as mild and well tolerated, and it blocks the 5-HT3 receptor. So it might be a good complementary or substitute antiemetic approach. Although there are several RCTs in the topic, the peppermint's efficacy in nausea and vomiting has not been established yet. So in our clinical project, our clinical question was, is peppermint oil effective in the treatment of treatment of nausea and vomiting symptoms in adults compared to placebo? The population was adult patients experiencing nausea and vomiting symptoms postoperatively due to chemotherapy or during pregnancy. The intervention was peppermint oil, the comparator placebo, and the primary outcome is the efficacy assessed by the changes in severity of nausea. We conducted our systematic search in 5 databases. Here are the hits and the final search key, and after the full text selection, we included 19 studies in our analysis. Our outcome was the severity of nausea and vomiting. The symptoms were assessed on a 0 to 10 scale, where 0 means no symptoms and 10 means the most severe symptoms. Also, nausea and vomiting was assessed at several time points, and in our statistical analysis, we used mean difference. In the case of the postoperative patients, the symptoms are assessed between 5 minutes and 48 hours, and I would like to highlight the 2 to 6 hours time point, where the mean difference was minus 0.60. And although these results are favoring the usage of peppermint oil, these results are only statistically significant, clinically not relevant. In the case of the chemotherapy patients, their symptoms were assessed between 24 and 96 hours daily. And here, I would like to highlight that at all the observed time points, we could get a statistically significant and clinically relevant difference. In the case of the 24 hours, the mean difference was minus 1.85. In 48 hours, it was minus 2.23. In 72 hours, the mean difference was minus 2.41. And in 96 hours, it was minus 2.11. And in the case of the pregnant women, also their symptoms were assessed between 24 and 96 hours. And here I would like to highlight the 48 and 96 hours time points, where the mean differences were minus 0.51, and at 96 hours was minus 0.68. Although these are favoring the usage of peppermint oil, these results have only statistically significance, but not clinically relevant. Also, we assessed the risk of bias assessment by the ROB2 tool. The majority of the articles had some concerns, and even one article had high risk of bias. We also assessed the grade assessment for the certainty of evidence, and in the case of all 3 subgroups, for the nausea and vomiting severity, we got low certainty of evidence. So, in conclusion, in postoperative nausea and vomiting, we could observe some improvement within the 2 to 6 hours time window. In chemotherapy, we could see significant improvement at the whole 24 to 96 hour observation period. And in pregnancy, we could see some improvement at 48 and at 96 hours. The strengths of the study that this is a comprehensive review of peppermint oil inhalation for nausea and vomiting, including diverse patient groups as postoperative and chemotherapy patients and also pregnant women. Also, we only included randomized controlled trials and focused on peppermint as the intervention alone. The limitations of the study, that some of the included studies had few sample sizes, and also in some studies, different measurement tools were used. Also, there were some variations in dosage and formulation of peppermint. For practice, we suggest that peppermint oil inhalation could demonstrate efficacy as a complementary option, and it is particularly useful for those patients who are unable or cannot use standard antiemetics, but it should be used cautiously, as the current evidence remains low in certainty for now. For research, we suggest larger, well-designed RCTs with standardized dosing, and these studies also should examine the mechanisms, quality of life, and patient-reported outcomes. The second project is efficacy and safety of L-menthol during gastrointestinal endoscopy, which we conducted with the method of systematic review and meta-analysis. Every year, only in the US, there are more than 7 million upper endoscopies and more than 13 million colonoscopies performed. Peristalsis, which is a natural movement, can make difficult to visualize abnormalities like adenomas or lesions during the endoscopic examinations. For this, the suppression of the peristalsis is needed to improve the detection of the small lesions and also the accuracy of the diagnosis. And for this, antispasmodic agents such as Buscopan or glucagon are used to inhibit the peristalsis. But these current pharmaceutical products are not always effective, or they can come with unpleasant adverse events. And for these situations, there is a need for an alternative option, and L-menthol might be a good one, as it has a gastrointestinal smooth muscle relaxing effect, and it is locally acting as a calcium channel antagonist. And there are some studies which mention that intragastric spraying of L-menthol could inhibit peristalsis with fewer adverse drug reactions. But although there are several RCTs in the topic, L-menthol's efficacy in upper endoscopy and colonoscopy has not been established yet. So our aim was to assess whether L-menthol could be used as a quick-acting, non-inferior, as safer alternative to antispasmodic agents during endoscopy. Our clinical question was, does L-menthol improve the lesion detection rate during endoscopy in adults compared to placebo? Our population included adult patients undergoing upper endoscopy or colonoscopy. The intervention was L-menthol, the comparator placebo, and the primary outcome, the quality of endoscopy. We conducted our search in 5 databases. Here are the hits and the final search key. And after the full text selection, we included 16 articles in our analysis. The first outcome was the proportion of no peristalsis in colonoscopy and upper endoscopy. In this case, it was assessed on a 0 to 4 grade scale, such as no, mild, moderate, severe, and very severe. In this case, the endoscopist was grading it, and we used in the statistical analysis odds ratio and dichotomized the grades as no peristalsis versus any kind of peristalsis. And in this case, in the colonoscopy group, our odds ratio was 3.06, and in upper endoscopy was 4.47. So we can conclude that it is beneficial to use menthol in both cases, and these results are statistically significant and also clinically relevant. The second outcome was the ease of examination for the operator in upper endoscopy. In this case, the operator had to assess that how they found easy or difficult the endoscopic procedure for themselves. And it was on a 4-grade scale, from very easy, easy, difficult, very difficult. And we used here also odds ratio. We dichotomized these as very easy, easy versus difficult, very difficult. In upper endoscopy, the odds ratio for this was 2.53, which is also favoring the usage of L-menthol in endoscopy, and this result is also statistically significant and clinically relevant. And the third outcome was the reported adverse events during the endoscopic procedure. And here we can see that the odds ratio for colonoscopy was 0.84, and in upper endoscopy was 1.06. So let's start with upper endoscopy. As you can see that in the odds ratio, it is close to 1. So it shows that there is no significant difference. So we could not see more adverse events in the L-menthol group compared to the placebo. And if we switch to the colonoscopy, here we can see that even in the L-menthol group, there were less adverse events reported than in the placebo group. We also assessed the risk of bias assessment by the ROB2 tool, and in the case of the upper endoscopy studies, we had low risk. Meanwhile, in the colonoscopy studies, some concerns. We also assessed the grade assessment, and for proportion of no peristalsis, we got a very low certainty of evidence. Meanwhile, for ease of examination and adverse events, we got moderate certainty. So, in conclusion, L-menthol reduces peristalsis and could potentially make examinations easier and smoother without observed increase in the adverse events. So, L-menthol could offer antispasmodic benefits for both the colonoscopy and upper endoscopy and might be a promising alternative for patients at risk. The strengths of the study, that this is the first comprehensive synthesis of L-menthol, including both colonoscopy and upper endoscopy, and we used advanced statistical methods and covered various outcomes. The limitations of the study, that most of the studies conducted in Japan, and around 1/3 of the studies had inadequate blinding. And also some included studies had small sample sizes. For practice, we suggest that L-menthol might offer a safe and effective alternative, especially for those patients who cannot receive the traditional medications. For research, we suggest to conduct larger multi-center trials to confirm the efficacy and safety across diverse populations. And also, the optimal dosage, frequency, and duration of L-menthol should be explored. And the third project is Elixirium timicompositum in the treatment of acute bronchitis in pediatric patients, and it is a protocol of an unicenter randomized double-blind clinical trial. Acute bronchitis is the inflammation of the large airways of the lung, and worldwide around 5% of the population reports an episode of the disease every year. Although in the majority of the cases, acute bronchitis is caused by viruses, there is still a high 70% antibiotic overprescription rate for patients diagnosed with the disease. Although antibiotics are not necessarily needed, but symptom management, yes, and for this, an alternative treatment is needed. And Elixirium timicompositum could be a good one. It is a Hungarian herbal medicinal product, which is used for decades, of course with some modifications in the recipe during the years, for the treatment of inflammatory processes of the respiratory tract, and its active ingredient is thyme tincture. And although this product is used for around 100 years traditionally, there is no any clinical trial conducted about its efficacy and safety. So our aim was to assess the clinical efficacy and safety of LX-TIMI to ensure its safe and rational use. Our clinical question was, is Elixirium timicompositum safe and effective in the treatment of acute bronchitis compared to placebo? Our population included pediatric patients with acute bronchitis, the intervention, the LX-TIMI, comparator placebo, and the outcome, the efficacy, assessed by the bronchitis severity score. And shortly about the protocol. On day 0, the patient and the parent is visiting the doctor, where the doctor will decide the eligibility of the patient, and after they assess, the doctor will assess the total bronchitis baseline score. This bronchitis severity score is consisted of the 5 most important symptoms of acute bronchitis, which are coughing, sputum production, nasal auscultation, chest pain and coughing, and dyspnea. After that, for 5 days, 3 times a day, the patients will take Elixirium timicompositum or placebo, and on day 7, they are going back for a follow-up visit, where the doctor will assess again the total bronchitis severity score. And the efficacy of the product will be assessed by the change between the day 7 and the day 0 bronchitis severity score. We plan to start to conduct the clinical trial in November 2025. We will use LX-timicompositum or an identical placebo. It will only not include the active ingredient, the thyme tincture. The trial will be conducted in the Női Egészségközpont in Szeged by 2 doctors, and also they will fill out paper forms during the trial to collect the data and also collect them in the REDCap electronic system as well. Both of my systematic review and meta-analysis are published in Q1 journals, and during my PhD journey, the number of all publications are 12, with a cumulative impact factor of 51.755. Also, I had some additional activities during my PhD. I had some years of laboratory work at the Semmelweis Pharmacology and Pharmacognosy departments. Also, I presented my topics in several conferences, and I was working as a scientific methodology supervisor for a year in the CTM. And I would like to thank my supervisors, my colleagues, my friends, and especially my family for their support during my PhD journey. They made this possible. And I would like to finish my presentation with a quote from Marie Curie: "Nothing in life is to be feared, it is only to be understood. Now is the time to understand more, so that we may fear less." Thank you for your attention.
We have to thank you for an excellent presentation. Thank you very much indeed. Also, similar field, but not the same. And indeed, not the same. And you presented us, again, very interesting results from large meta-analysis. I was first impressed of the number of studies you have selected in the beginning, of more than 1,500 in the first vomiting study.
Yes.
Is that really true? So
yeah, I can show you.
And then you downsize this to 14 or so, or in this range. So could you just tell us again what were the criteria? Because I think this is significant to downsize it from 1,500 down to 14.
By my experience, yes. So I can start that way, that from the methodology concept, that when we are creating the search key, it is very important to include everything. Sometimes it's hard, there can be synonymous. As we are checking several databases, sometimes they are indexing things different way, or also they are sometimes check only the title and abstract, sometimes the full text. So we have to make sure that the search key that we use, that it will not miss any of the articles that could be a good target for us. So sometimes it happens that we have to extend a little bit more and accept that how many articles we find. But just to clarify, this 1,547, those are the articles before the duplicate removal. So after this, that I collected from all the 5 databases, the articles, then first I removed if the same article happened several times. So as you can see here, that almost 500 articles I could delete without even checking it. And for this, we used to use also automatic removal. So there is in the EndNote, for example, that option that is showing for us that which can be possible duplicates, and we have to check, of course, by ourselves too, that if we accept, if it finds it. But it's not perfect either, because in some journals, so you know that it's showing the metadata of the article, and sometimes if the journal name is in the short way, and in the from the other databases in the long way, sometimes it doesn't recognize it's the duplicate. So we have to also do after that a manual selection too. And after that, we basically started from 1,000 articles. But even after that, the next step was just to check the title and the abstract of the articles. And if we use some keywords after, then we can exclude easily some articles. So for example, here we were looking for human research. So I could write mice, rats, animals, and so on. And if I found it in the abstract, then I just made sure in those sentences, because also sometimes it can be tricky, because sometimes they include the introduction of they used to do or they did before on mice, some research, and now we are checking on human. So also that can be tricky, but it can make faster and easier the way to select out. And after, basically, the only 72 articles were that we had to get the full text and make sure that after our final eligibility criteria were happening, so if it was true or not, and finally we got this 19.
Okay, thank you. Yes, it's an extremely important work to really find out the relevant papers.
And also we used to do in parallel, so I do the whole process with at least one pair.
Yeah, okay. May I go just into the of your first meta-analysis into the studies comparing post-surgical patients and pregnant women? If I noted it right, the major effect or significant reduction of nausea and vomiting in the post-surgery patients was maximum in the range of 2 to 6 hours, whereas it was in your paper was in the pregnant women it was between 48 and 96 hours, so much later. I don't know if I noted it right, but if it's the case, what could be the explanation?
For the date?
For this large delay in pregnant women?
Well, it is always a big problem for the pregnant women that how to manage for them this symptom management, because, for example, the thing is that there is for it the doxylamine pyridoxine combination, what now is recommended to use, but even there are new clinical trials about it for conducting about the efficacy of the product, and as much it was popular and hyped before, seems that it does not have it's not that much effective like they expected from it before. So I could think that might be an option, that they really have the need, the push to look for alternatives for it. And as it is very limited, really, that which medications the women can take in the protection of the fetus, then seems that Also, I noticed when I was doing the selection of the studies for both studies with the Peppermint and the L-menthol, that I could find some studies from, 20 years before. And after, for a while, nothing, and now it starts to be again popular. So, for example, it was funny that when I was looking for some support or help from professors, then I could find sometimes that they said that, sorry, I am already retired, but they could have been especially good for my topic to help because they were researching before, but we try to get again into the topic to do. So, seems that there was a time when we started to produce a lot medicine, and because we have now the technology for it to also plan, and also with bioinformatics, it is very much improving. But I can see or think that some of the researchers are trying to get back to the natural compounds, to the origins, to the source.
Thank you. Congratulations.
Thank
Nice presentation. Basically, similar questions can be asked here as in the previous study. My first question is, if I remember well, you used the phrase statistically significant but clinically not relevant in several cases. In the case of an antiemetic effect against, in pregnancy, I think, and also in the case of post-operative nausea. So actually, what is your recommendation in this case? So should we use these peppermint oil or not?
Yeah, in the case of the post-operative patients, that first I was very happy that I found a lot of articles which were conducting research about this. But after that, when I was analyzing the basic characteristics of these studies and I digged deeper, then I could get the sad truth that actually these included articles mostly are not having the same surgeries. So that is a huge limitation, which we also highlighted in our articles. But what I can suggest here, that so for the first thing was just to have like a screening, that even if we should try to focus or even try to do more trials about it. So what we thought that will be like a promising conclusion. It could be only just like a kind of recommendation that we can see that it has, for now, a slightly better effect than placebo. But of course, as I mentioned, it has a very low certainty for now because there was a high heterogeneity of these studies.
Mm-hmm. Okay. And you also found that actually that maybe the best effect can be achieved in the case of cancer treatment. So. Yes. But I would assume that that's an even more severe situation than more severe nausea and vomiting than in the case of pregnancy. So how would you explain that this peppermint oil is actually more effective in against cytotoxic drugs than against this physiological pregnancy associated nausea?
But the two things have different source. That how nausea vomiting is happening in these two cases. So one of the cases like hormonal changes, and the other one can be the anesthetics, the opioids. Also, in this case, when you have a surgery, then you have like an invasive procedure in your body. So what also was different in the postoperative studies, that we also had to consider that which organ was impacted in this, and also when there was the recovery time of the patient, it was a kind of like, let's say, stress for them to have this, they also get these anesthetics or opioids. So several things happen to the body, which was like, let's say, not normally working because the patient was sick. That's how I had the surgery. But that has like a different rhythm or flow that how in the pregnancy, actually, the hormonal changes having the effect like constantly for them. And I don't have the experience yet, but I think that also is totally different to have every day that kind of nausea than just from one day after the surgery.
That's completely true. And basically, you are saying that they have different pathogenesis. Actually, I would say, and again, we can get to the question, the same question what rose in the previous defense, that what can be the mechanism of action here. So if this as peppermint oil inhibits better cytotoxic drug-induced nausea, so what could be here the effect maybe? So do you have any ideas? So what can be the mechanism of action?
What I would say, maybe first not the mechanism of action, but maybe also the severity of the symptoms. So what I would say that I think from a more severe nausea, vomiting, or even the more severe symptoms in general of things, it is easier to produce bigger difference. So if it's somebody just have a mild effect of something, it's also harder to detect. So because in this case they use the severity scales from 0 to 10. So if I am 3 and now I feel 2, that is like 1 point difference. But if I was like 8 or 9 and now I feel 4, that is a much bigger difference.
That's actually, I understand what your point. Yeah, it's true. But on the other side, I think if there's a more severe situation, maybe, I don't know, maybe it's more resistant to either conventional treatments or treatments like this. And actually, it's good that you are showing this, because I had a specific question related, a methodological question related to this analysis here, because your final conclusion here is that peppermint oil is the best against chemotherapy-induced nausea. But there's one study here, this Turk et al. Study, in which 5 different protocols were used, and all these sub-analyses were included separately into this forest plot. So at the first glance, we have, 8 studies in the analysis, but actually it's only, I would say, 3, and 5 of the data originate from the same study. And actually in this study, we also discussed it in the thesis. The control group was not appropriate. So I mean, there was there was no control group.
No, the opposite. There was
in the Turk group.
There was control group for every chemotherapeutic agent. So that was what I said in that's how we could include this, because every single chemotherapeutic agent had a placebo group, a parallel, which were not the same people in the chemotherapy groups.
Okay, so it's clearly stated as a limitation that there was a problem with this study, but even if there was no such methodological problem, so basically this is one study here which I think, I mean, it favors peppermint oil clearly. So in this case, my question is only, how can we, are there any strict guidelines how to use such papers or studies? So can we just put these data together and use this paper as one single randomized control trial, or we can just use these subgroups separately? So are there any clear guidelines here, or what is the? Because I have no experience with meta-analysis. So yes. How did you decide to use these data separately?
Yes, you are totally right about it. Normally it's that way. If this happens that there are several intervention groups, the problematic is when there is only one placebo group to compare, because in this case, always the change is going with the same placebo group's patients. But really in this article that happened, that we made sure, so we also asked data from the authors, and they made sure that these were all like total different patients in the placebo group.
Mm-hmm. Okay.
So in this case, it should be.
Okay.
So what Doris said was completely correct. The other thing that we can do is that we might need to assume that data inside this one given article is more correlated to each other more similar to each other than to other articles. And what we can do is take care of it statistically by including a cluster effect for the studies. So that way the models can take care of this higher correlation of the data from the same study and deal with the data then.
Thank you. Thank you. Okay, I have no further questions. Congratulations again.
Thank you so much. And thank you, Bence.
Okay, so again, I congratulate you. I'm saying nothing new here, but this is really a nice presentation and important things addressed here. Maybe I didn't pay enough attention when reading your thesis, but in the articles that you used for your final analysis, was there, you show us effects at 24, 48, 96, whatever hours. Of course, it was not a single administration, right?
No,
it was repeated. Not. How consistent was this repeated administration across the studies?
Yeah, in the
time points and also dosage and stuff.
In the postoperative setup, there I can say that how was. I am always clicking the wrong button. 1 second. Yes, here. So here, the inhalation of the peppermint oil was after the baseline, and they were assessing at 5 minutes. But in the case of the next hours, they had occasionally the peppermint oil inhalation. So like they had actually the protocol for the patient because they were in the hospital, so it could be managed in a very easy way. So the nurses were giving for them. So here was a little bit less consistent, and that's why we were using time windows instead of exact time points. So that's why you can see here like 2 to 6 hours or 6 to 12 hours, because sometimes we saw that they assessed the symptom after 6 hours and sometimes after 8 hours. And unfortunately, we could not have a lot articles, a lot. So for this, we had to use, by some limitation, these to try to merge together some periods of time for this. But we think that how it can take for the patient to have the nausea vomiting symptoms for several days even, then it can be like a kind of direction to show that what we can expect from it if it is used. In the case of the chemotherapy patients, also they had a daily peppermint oil inhalation. So also it was in the protocol. Here it was more consistent that how many times they had to inhale the peppermint oil. And in the case of the pregnant women, also they had a daily, so here we could include 3 articles. In 2 articles, they had only the rule to inhale when they feel nauseous, and they had to assess the score like once a day. And in the 3rd article, there was like a bowl full of water. They put in it some mint, and they put under the bed for the whole night. And that was the intervention itself. So of course, it is coming with a very high limitation, yes, but actually this is what we see that this is the way that how currently we have publications about this. So we're trying to highlight, to have more research also with better methodologies and also more consistent setup.
Okay. If you planned the study, if it were you planning that study, you wouldn't have planned it like that, putting it under the bed and, temperature, air conditions, whatever. Yeah, it's more like astrology in this case, I'm sorry. Yeah, so regarding the anti-cancer therapy, it's a very broad definition, right, what you used here. Obviously, different studies looked at different anti-cancer therapies. For example, for platinum compounds, it's quite famous for having such a strong nausea, vomiting,
like
effect that they just refuse
might
even refuse the treatment. So, did something emerge from you from these studies? Looking at these studies, in what cases or in what kind of therapies this intervention would be more useful as opposed to not so useful in some others?
Yes, actually we see the most efficacy in the case of the FOLFIRINOX. But also we could see that here was a huge limitation too, that there were several cancer types in these studies. Also, in some studies, they only just defined that we are including patients with any kind of cancer. Not in too many cases, but it also happened. But most of the times that we really had different organs. And also, of course, it comes with different chemotherapeutic agents. So what I can say that currently I cannot give recommendations for any because I need more data for that to have something more certain.
Okay.
But what it can be good for the beginning is that it can be a good start, like for what it could be even promising to start to focus on and even maybe include more patients. Because how there are several chemotherapy agents, there are several cancer types, it would be the best to have this trio together that where can be more efficient together, the three.
Regarding the second part of your presentation, again, maybe I missed something, but what would you say if somebody from the street would ask you after reading your work that why would the candidate expect any effects of menthol on adenoma detection rate? Why?
Yes, so actually adenoma detection rate, that was our planned primary outcome. And this is what we also defined at the beginning of the protocol besides our other outcomes. And also, we actually made the analysis about it. So I brought it for you if I can present it. We can discuss it, just a second. Yes, it's here. What you can see here, that the odds ratio of the adenoma detection rate was 0.99, which was actually showing that there was no any association. So we were thinking about it, that what can cause this, because this is the gold standard, and this used to define the quality of the endoscopy. But we were thinking about it, that what could it cause, that although the adenoma detection rate, we got this result, but we could see that the peristalsis grade was, the peristalsis grade was, that we could see statistically significant and also clinically relevant changes, that what is causing this, that we could see that that was an antiperistaltic effect. And we were digging deeper to the basic characteristics of these studies. And what we could see, and what I don't understand for now, that in the inclusion criteria, then they defined it as screening patients, or when they have a positive fecal occult test, or also when they are asked back for second examinations. So there are also these things. But for me, what is bothering me the most, that there are some studies which only included the patients who are coming for screening examinations. So the thing is that if they are coming and there is no any adenoma found, then we cannot be sure that if it was even there. So we concluded that for our study or for our aim, then adenoma detection rate is not the good indicator. And we focus more on the peristalsis.
Do you have any insights from the literature on the purported or proven mechanism of action of menthol on the antispasmodic effect? What would be the mechanism, or maybe several mechanisms behind that?
I read the pharmacokinetic research about it, where actually they were checking in 3 concentration of 0.4, 0.8, and 1.6% of L-menthol to use, where they were screening through the time that what is the effect of it. So they were monitoring the whole time that if any spasm was occurring or no for I think for 20 minutes or 30 minutes, and according to that.
I mean, molecular mechanism of action, like maybe some ion channels might be involved.
Sorry?
Maybe some ion channels might be involved here in smooth muscle, regulating?
Yes, so it has a 5-HT3 serotonin receptor antagonist, and also the other factor is the TRPM8 ion channel. So it has also like a cooling sensation. So it both are making part of this.
Maybe L-type calcium channels might be involved also. So just that point, my point.
Yes.
Okay, no further questions. Thank you.
Thank you so much.
Congratulations to you. You have presented a very complex but real nice job. And I have only a simple question. Generally, the comparator was placebo. Could you evaluate or analyze the placebo requirements or content? Have you found every time the content of placebo? But
Yes, in which project you are asking, sorry? The inhalation or the endoscopy?
and generally, you have presented several studies and
Yes, in several cases, in the inhalation, they used like saline, or sometimes they used like almond oil, for example, in both of the groups, and they diluted the peppermint oil into that because it has no scent, but at least it is for them visually a little bit closer to essential oil. So it was very different that how they try to manage the blinding of these studies. And we could see some good examples when they try to scent the room with some drops of peppermint oil, because it is very distinguishable, the smell. So actually, it is the problem with in general about aromatherapy, that how to manage placebo groups. But also, even they considered in some of the studies this as double-blind. So for this, at least from the doctors or the nurses' side, they try to put like some peppermint scent also on the mask or on the gloves. And but indeed, it is very hard. And I try to think about it, that how could this be solved. But for now, the ways that how they did, I cannot even suggest a better option. But in the case of the endoscopy projects, in my opinion, there was a much better situation, because in this case, I can show you the photo that actually how is applied the L-menthol. I think. So if you check the endoscope, then in that case, it has a working channel, and through that, the patients got the prepared syringe. So prepared syringe was on the table from before, and I was discussing with the internal medicine specialist about it, that what he would think about it, if he would still feel the smell or no. I said that, yeah, maybe with scented mask or with the room, then it might be possible to try to blind it from the doctor, because in that case, if we check the adenoma detection rate, for example, it is very crucial for the investigator to be blinded. But at least for the evaluation of the peristalsis, it was very interesting that at least I would say that there the blinding was good, because as the patient, I think during the endoscopy you cannot really like modify your spasm, but they hired an individual committee group, and they recorded the endoscopic procedure, and after they sent for them the video recordings, and they had to evaluate the peristalsis. In that case, the patients were coded, and also the smell was not an issue. So at least about it, we could make it in a more optimal, or they could make it with a more optimal setup.
I have two questions. One is again taxonomy related. So peppermint is not strictly a standalone species, but it's a result of a hybridization of watermint and spearmint.
Yes.
Did you consider including those two as well in the first analysis? Because in the search key I saw that you only focused on peppermint and menthol peristal.
Yes, the difference between these is the L-menthol content, the amount of it. So in the peppermint oil is where we have like depends on the geographical origin. But for example, here in Central Europe, the L-menthol content is between 35 and 50%. And even it's very interesting that if we are in this topic, if you may let me talk about it, that for example in Europe, to use the peppermint oil inhalation during the pregnancy is not recommended because of the menthoforan and the pulegon content. But I saw that I checked internationally, and for example in the Australian guidelines, they suggest. And I was checking that what could make the difference between these. And actually, I found a study from Tasmania where the peppermint has that modification through the geographic origin or location, also the weather and all these factors, that the L-menthol content was even higher, like up to 70% or even more, and the menthoforan and the pulegon was much less, was around 1%. Here is around 5% of the content. So it can modify even this much, the amount of the content. But also, I could see that more studies focused in the literature about the peppermint, but mostly for the L-menthol content.
And my other question would be related to your third study. So in the study design, I've seen that you evaluate bronchitis severity at day 0, and after that 5 days of treatment, 1 day without treatment, and then evaluating bronchitis severity again. So my question would be what is the, I don't know how to say it properly, the natural pathway of bronchitis, so how long bronchitis regularly lasts?
For 1 to 2 weeks used to be normally, yes.
So then this 7-day follow-up time should be proper, and it should not be shorter or something?
Even that much is proper, that the product itself is not recommended to use more than 7 days. So if the symptoms are still on, it is suggested by the factory to go back to the doctor. So yeah, that is the limitation, but we discussed that to take it 5 days is actually, if you're curious why day 6 is missed and day 7 is the follow-up visit, it has logistical reasons. Because
the bottle is that big?
Is for the doctor's availability, because the family doctors used to work between Monday and Friday, so we had to make sure that it will be always and consistently happen the same day, the follow-up visit, and it's not happening for a Saturday or a Sunday.
Okay, thank you.
Thank you.
Congratulations, Dori. Amazing work. I had 2 questions regarding this one. I was really curious. First is you have 2 arms. One of them is placebo and the other one is the TIMI. Yeah. Do these patients take any standard treatment, standard care, or only these 2?
No, they don't take, so actively they don't take anything, because normally acute bronchitis does not need any treatment, only just during the disease we need some symptom management, so basically we just make easier our life if we are taking something for that. But it is not so it is possible to take some kind of additional treatment during it, but we write it down in the inclusion and exclusion criteria, that what can be and what cannot be used before and meanwhile. So for example, if the patient's severity is getting much higher, so they get more sick and L-extim is not enough for them, and maybe even they need antibiotic treatment, that case we will immediately terminate for them the trial, and of course they will start the antibiotic treatment. But at the beginning, in our inclusion criteria, we include that the bronchitis severity score, which is from 0 until 20, we will only include patients who have the baseline score between 5 and 12, because we consider them patients with mild effect. So as we talked about it before, that if a patient has a very low the points, then from that it's very hard to show if they get better or improve their symptoms. So we had to find somewhere in the middle of the scale to include them to kind of make sure that they will not get worse, but we will get a detectable change or difference between these 7 days.
Okay, thank you. My second question was about the bacterial one, but you proactively answered that, so thanks.
Thank you.
So I'm happy that we got question for the third topic. I have only one additional question because it's performed in children.
Yes.
Which is, why do you start in children and not in adults? Because this is always a vulnerable population, and first, normally studies have to be first performed in adults. Okay, it can be considered as a very mild treatment, so with mild effects. So, and that's why I have the question, is it good to suppress coughing in this disease?
Well, actually,
yeah, because it's
yes.
really a question which is important, because normally coughing is part of this disease, and it's important to cough away the viral ingredients and so on.
Yes, but also the time has mucus, so is reducing the mucus viscosity. So that is the part of the effect, and that's how it's more about like irritations. That if the patient is all the time like then that is the thing what we try to relax down. So really, it's for this. If they take this medicine, then after that they might not need that much or that intensity the coughing than normally how it used to be collected and produced there in that stage or status or format.
And you received already ethical improvement and so on for the entire study?
Yes,
Okay.
yes, it is accepted.
And it is running as a medication, or what is the legal background of the study?
Yes, it is officially a herbal medicinal product. Yes.
Okay, thank you.
Thank you so much.
We were just discussing this behind your back, sorry, just a quickie at the very end, that how do you control for household remedies, and the neighbor said something that the child should take, or they read something on Facebook or on the internet, and how do you control this, that what do they eat or drink or in order to relieve the symptoms?
Of course.
In the study?
So in this case, we informed the doctors who will work with us to give instructions for the patient and the parent. So all the time we expect that also the parent is coming together with the patient to the doctor, and there also we get the information, and we were also creating a leaflet for them to show that what they can take, what they cannot take, and also in lots of the cases, the problem that for 5 times a day, for 5 days, 3 times a day, it is very likely can happen that the child will forget to take the intervention, which is very bad. So we also made for them, for example, a checklist to take every day that they took it. So I worked on it and tried to make it as much more like motivating as I can, these things for them. And of course that our doctors will be available 24/7 to answer for them, so they can also call for some help. But we try to ask them to make sure that they were not using something. But on the follow-up visit, of course, we will ask the doctors to try to ask them that if really they did something or take something or they didn't take something. And we try to calculate a relatively high dropout rate. It was like 25%, which we also calculated in this, that they get more severe the disease meanwhile, or also that somehow they are not continuing the whole time, or they are just not appearing for the follow-up visit.
First applause. And I think the committee will retire now to assess those candidates. Thank you very much.
Thank you so much.
I have now the honor and privilege to announce the results of your defense. And I'll start with Esther. And the committee gave you a grade in average of 4.2. That's cum laude. Congratulations.
Thank you.
And Dorottya, the average mark was a little bit higher with 4.6, and that meets a summa cum laude. So congratulations to you. I can say we all wish you all the best for your future career, and please have a nice evening and celebrate your dissertation and PhD degree.
Thank you so much. Thank you.
Close now the session, or will you say some words?
I just would like to say some words. Of course, I would like to also congratulate to the students for their excellent performance and also for the supervisors to doing that. And finally, I also would like to thank for the committee spending their very valuable time with us for this day. And I think this PhD defense for those who are year one students, it's a very good example where you need to, and where you will actually end at the end of your PhD. I think it was also a celebration of science. Thank you for coming here. And tomorrow morning we will continue. So those who are here also come tomorrow, because tomorrow there will be other PhD defenses because we have now 22 within 3 days. And thank you very much again. Have a nice rest.